or facts expressed by the panelists on this television program. Please consult your doctor.
Hello, I want to ask you, do you remember when Lasik was brand new and the people who got Lasik were actually the brave people and we were like, oh, should I get it? How's his eyes? Is he going to be okay? Well, now it's been around forever and it seems like there are still a lot of questions about eye surgery. Cataract surgery seems to be one of those surgeries that's so common and everyone's getting cataract surgery these days. And today's title is called What My Vision Will Be Like After Cataract Surgery or After Lasik Surgery, and then we've got other surgeries mixed in there. So during this next hour, we have experts answering questions about ophthalmology, all kinds of eye surgeries, and we're going to talk about corrective measures, risk factors, and treatments. And as you know, this is a live program, so give us a call at 881-0013. This program is underwritten by Southwest Eye Institute. Thanks, guys. And we also want to thank the Texas Tech Paul L. Foster School of Medicine for providing the students here tonight. And if we can get a shot of them, we have Melissa Huddleston and also Heather Jones with us. So if you can wave and say hi to the audience, these are the two young ladies who are going to be answering your questions, and then they're not going to answer your questions. They're going to write down your questions, so be articulate and tell them to use good handwriting. They actually both really do, which is very helpful. We also want to say a huge thank you to the El Paso County Medical Society. This is now going into the third decade of them underwriting this show. So happy new decade to all of you at home. Good evening, I am Catherine Berg, and you are watching the El Paso Physician. So what will your vision be like after Lasik surgery or after cataract surgery? That's the big question. It's the fear of the unknown, and sometimes we don't know what's going to happen, so we just tend to put it off and put it off and put it off. So this is that show that can help us understand what it's going to be like. And those of you that have put it off and finally have done it over the last several years, I know that you're telling your friends, man, I wish I'd done this earlier. I know that you all hear that all the time. I hear that all the time. With us today, we have Dr. Mark Ellman, who's an ophthalmologist, and we have also Dr. Javier De La Torre. Both of them are ophthalmologists, but I'm going to say a little bit about you, and then I'm going to have you guys talk about yourselves. But Dr. Mark Ellman loves El Paso. He's from New York.
Correct.
And winters in New York are just no fun. So
nope, neither are Texas.
Neither are taxes, is that what you said?
Yep.
Taxes are not too bad in Texas when you're looking at the rest of the country. There are some states a little bit better, but we're around that time. Dr. Ellman, founded the Southwest Eye Institute in 2004, and then Vista Surgery Center in 2007, and he's dedicated to cataract surgery, and he's also going to be our glaucoma guy this evening. And then we have Dr. Javier De La Torre, who is from Puerto Rico, and it's just nice to say that, an eye surgeon with the U.S. Army, and he was based at William Beaumont Army Medical Center prior to joining the Southwest Eye Institute. He's dedicated to comprehensive eye care and laser vision correction, and he's the specialist with Lasik and PRK, and there's all kinds of acronyms that we're going to talk about tonight. So, Dr. Ellman, for the audience at home, as people are watching the show, how would you describe what you do all day, every day? And that's going to be the same question to you. So you're both ophthalmologists, that's easy, but then you both kind of have your specialties. I said a little bit about it, but how would you describe it?
Correct. So one of the things we do at the Southwest Eye Institute, we're pretty specialized. So I spend almost all of my time doing cataract surgery. Dr. De La Torre spends a good portion of his time just doing Lasik and PRK. And so that allows us to really focus on those, on what we do. But we also both do comprehensive ophthalmology like most of our group.
Okay.
And you had mentioned before, a lot of people are just they're scared of the unknown.
Right.
And so I'm glad we're talking about that tonight, because a lot of people do exactly what you said. They have cataract, they wait. That they have cataract surgery or Lasik, and then they say, wow, I should have done that a decade ago.
Right. And I was one of those people. I mean, I can't even stick contact in my eye. My eyes are that sensitive, but that's just an excuse. I mean, it takes me an hour to get something in there, so I just wear eyeglasses. Or luckily, I'm still at the point where I can read without anything on. But Dr. De La Torre, so you are a Lasik guy. Now remember when we had you on last time that there are beautiful prime ages when our eyes grow, and then they kind of hang out in that area for 2 or 3 decades, and then they start changing again. So we're going to talk a little bit about that. But with Lasik, what is again, that's your specialty, but how would you explain that to the audience?
Well, the laser is approved for ages 18 and above by the FDA, but we like to start to evaluate the patients at that age and make sure that the prescription stops changing. And the patients usually, when we determine that they're ready, surgery, it's a very safe procedure that we try to make it as comfortable as we can, but still it's surgery, and so we take it with very much care and precision, and so patients go in for an evaluation. Once we determine that they're ready for surgery, we proceed, and the surgery actually takes 10-15 minutes. I was convinced that I wanted to do it because I had it myself when I was in the Army, and that's when I was bought in that this is something that I needed to share with other patients. And so I've been doing it for now 10 years, and it's in the correct patient and done for the right reasons, it's a life-changing surgery.
I bet it's a life change. So I just had a prescription change, and I'm that girl. I even have my name on my phone. I'm the girl that puts my eyeglasses down, my phone down, and I walk away. And I wish I had done it years ago. And now I'm right at that age where I need to find my position again. I'm 52, find that position again where my eyes stop changing, and then get the other surgery. But what I want to do before the show really starts to get going, so ophthalmology and optometry, two very different things. And I want to bring that to light for our audience at home, because sometimes it comes out of the mouth so quickly that there's not a difference that people know. So explain optometry versus ophthalmology. You all are ophthalmologists. If you could really quick explain what the difference is, or how you define the two of them.
Sure. So Dr. Della Torre and I are both ophthalmologists, which means we went to 4 years of college, 4 years of medical school, 1 year internship usually in internal medicine in a hospital, and then at least 3 years of ophthalmology training.
Okay.
Optometrists take a little bit of a different path. They're also eye care providers, and it runs the gamut in optometry. There are some optometrists that focus on glasses and contact lenses, and there are some optometrists that focus more on medical care of the eyes.
Right.
The big difference between the two specialties is optometrists don't do surgery, ophthalmologists do.
Okay.
And
so, yeah, go ahead.
As I said, we have both in our clinic. So we have optometrists and we have ophthalmologists. Our optometrists focused on medical care only, like a lot of the other optometrists in town.
And that's the big reason I wanted you to say that. So when you have a medical issue, you see things really, not just that your eye vision is changing, but maybe you're starting to see shadows, or there's a focal vision that's leaving. That's where an ophthalmologist really might be the person to see, or someone in your office. I mean, if we could, there's a PowerPoint that we have, and if we can just start that actually, and we can pass slide 1 if you'd like, and go to slide 2, which would be kind of what we're talking about right now, because there's multi-specialty within ophthalmology, a couple of locations here in town. I know they're going to pop that up in a second. Dedicated eye surgery center, and if we can go through the slide number 3 now, you'll see two handsome men. Slide number 3 is Dr. Della Torre, but it shows you here the sheer number of doctors that are with the Southwest Eye Institute, and then slide number 4 will be Dr. Elman. So the nice thing here is that you really have a good number of names and a good number of specialties that you go through, and that's so important. And on that note, I would love to go to slide number 5, because this then is going to be kind of the jump off point of what we're going to be speaking about this evening. So there is a graphic of a healthy eye. And either one of you, who would like to kind of walk through this and tell us what we're looking at?
So,
Dr. Della Torre?
Yeah, I like to explain the eye as the fanciest camera ever built. And so we have the first lens of the eye is the cornea, and that's the first lens of our camera. And then we have a lens inside the eye. So we have a 2-lens camera system. And then the light is focused like a camera into the film of the camera that is called the retina. And then the retina captures that image and downloads the picture to the brain via the optic nerve, which is in the back. So it's a fancy camera.
And if you want to go to slide number 6, as he's speaking, you can just see it bigger, if that helps. There
Correct.
we go.
And
okay.
so here we can focus on the cornea, which is typically where Lasik, PRK is done, versus on the lens, which is what will become eventually in everybody a cataract, and that's where we do cataract surgery.
Nice. And you mentioned Lasik PRK, and I don't want to get out of order, but I do want to look at slide number 7 before we start getting into cataract. So, Dr. Della Torre, you're on again because this is your specialty.
Correct.
So Lasik and PRK, and let's in that same question. It used to be RK, then PRK, LASIK. If you can explain the differences between all that.
Correct. So RK was the first refractive surgery procedure that was done, and that stands for radial keratotomy. And it was a surgery that was exclusively to get rid of nearsightedness or myopia, and it was incisions that were created on the cornea. What we found over time is that RK, unfortunately, is the gift that keeps on giving, and the cornea continued to flatten, and unfortunately, those corneas never achieve a steady state. The prescription continued to change, and the FDA removed the indication, so RK is no longer done in the United States. It's not FDA approved. So then it was introduced laser-based surgery, and lasers that we reshape the cornea. Essentially, I like to explain it to the patients as it's a very precise carving tool, and your prescription, we measure it very accurately, and the laser will carve your cornea to carry your prescription permanently.
Okay.
And so the difference essentially between PRK and LASIK is that in PRK, we remove the first layer called the skin of the cornea, the epithelium. We carve the cornea, but that skin has to grow from scratch. So that's why
interesting.
That's why it takes a full week to recover.
I see.
LASIK on the other,
it can do that in a week.
within a week, it recovers.
Goodness.
Versus with LASIK, what we do is we're gonna use a laser. Used to be done with a blade, no longer. We do it with a laser, where we're gonna create what is called a LASIK flap. It's a piece of cornea that we lift just for the purpose of the surgery. We use the same laser as PRK to carve the cornea, but then that wound that we created that in PRK has to take a week to heal, with LASIK we place the cornea back down and instantaneously heal. So usually the LASIK patient the next day see the results versus the PRK patient takes a full week to recover. And that's basically the difference between LASIK PRK. So it's the same surgery. One we cut the cornea, one we don't cut the cornea. One takes a day to recover, one takes a week to recover. But both can do the same job in getting rid of the glasses, and some patients are not a candidate for LASIK. They're only candidate for PRK. For example,
That's a great point. Okay.
correct. Patients that have very high prescriptions, they cannot get LASIK.
Okay.
Patients that have abused their corneas from contact lenses, they have scars or blood vessels growing, they cannot get LASIK. Patients like me that are at risk of trauma when I was in the Army, so athletes, law enforcement, they tend to get PRK, not LASIK.
Gotcha.
Or patients that had prior LASIK and they want to have a touch-up to their LASIK. Typically, we do PRK on those patients. We don't like to cut the cornea twice.
So say that again, because that will be a question, I bet.
Correct.
So someone who has had LASIK already,
Correct.
and now they need another adjustment.
Exactly.
Talk a little bit about how
Correct.
and why and what that would be.
Yeah, so let's say, for example, and this is most of the patients, they come to LASIK before age 45.
Okay.
So we would do LASIK, both eyes. We aim for distance because patients have the ability to see up close, God given. After 45, the vision starts to change in everybody, and that's called presbyopia, where the lens inside the eye starts to get stiff and cannot help us see up close. In those patients, we can go to the store and get reading glasses, but that's inconvenient. So patients can elect to have a touch-up to their LASIK, and we do it where one eye is aimed for distance and one for near. That's called monovision. And typically that touch-up, we do it with PRK. We don't like to cut the cornea twice. So we do PRK touch-ups, which takes a week to recover, but the patients enjoy the same result as LASIK.
And I'm hearing more and more about that one eye is set for this way, and then the brain. Talk about how the brain just adapts to that.
Correct.
Because you just think intuitively, well, then you're going to have to do this all day, but you're not.
Yep. You're not, and because the brain from the time you're born selects one eye to be the dominant eye, just like you have a dominant hand. We determine that before the surgery. So once we determine which is the dominant eye, that eye is the one that we aim for distance. Something natural, like when you grab a camera, you go to your dominant eye, or when you're shooting, you go to your dominant eye. So that's going to be your distance eye. And then the non-dominant eye becomes your near eye.
Okay.
And we go through a process where prior to doing it, we test the patient's ability to tolerate it with contact lenses. So before we engage in the surgery, we test drive the treatment with a contact lens. So instead of just adventuring with the laser and then figure out that brain is not gonna get used to monovision, we try it on contacts. So the patients, we feed them with contacts, they wear them for 2-3 days. If the brain adjusts to the contact lenses monovision, it's gonna do very well with the adjustment with the laser in monovision. And the transition is that usually under 45 gets both eyes distance. Between 45, 55, you develop the need for reading glasses. We do a touch-up. And then your brain gets used to monovision by neuroadaptation. Your brain will always select the better seeing eye. So if you have a distant object, the brain uses more the dominant eye. If you aim a near object, the brain uses a non-dominant eye and does it without you having, like you said, having to open. The brain does it automatically. Once the brain gets adjusted to that, then you can carry that for the rest of your life.
Right.
And then at the time of cataract surgery, that we'll talk about that later, you can do monovision with cataract surgery. And now you're without glasses for most of your life. So essentially a patient that at 18 gets LASIK, in theory, could be for the rest of their life without glasses, because at the time of 40, 45, when they lose their near, they get a touch-up, and then at the time of cataract surgery, they can continue with monovision with cataract surgery. And
That's
then they're
amazing to me. It's almost science fiction-y, you know, how that has worked. And again, I'm 52, so I remember when I was in my 20s, and I am slightly nearsighted, so luckily it's never been an issue, but I thought, man, that's kind of cool. And then 5 years later, it's like, now it's this. And then 5 years later, now it's this. You were beautiful in transitioning and talking about cataract surgery. So what I'd like to do, Dr. Ellman, first is to describe, and slide number 8 is going to show this beautifully, describe what a cataract is. And we also have a model here on the table. Let's do the slide first for a while. And we also have a model on the table that shows us different types of cataracts or stages. But explain what a cataract is and how it develops, about when in life they develop, if they're going to, etc.
Sure. So if you remember when Dr. Della Torre was going over the anatomy before, you had the cornea, the front surface. If I poked you in the eye, I'd be poking you on the cornea. That's where Dr. Della Torre does his LASIK or PRK, and where they used to do RK. Behind the iris sits a lens that we're born with. And that lens, as a normal aging process, like everything else unfortunately, starts to develop, changes with time, and becomes cloudy. The average patient's probably in their 70s, but we've had patients with adult onset cataracts, you know, as low as their 20s.
Oh, goodness.
But usually when you're younger, a cataract is related to either medications or trauma. Or being born that way, congenital cataracts. Older people, their age range varies, but most patients are even about in their 70s. It's actually the most common surgery performed in the United States, because almost everybody gets a cataract, and they typically get 2. So if we look at the graphic that's on the screen right now, when you're looking at the patient at the pupil, the black part of the eye on the left, you can see it's nice and black because it's just clear lens, and on the right, it's starting to become a little white. So some people, you can actually see their cataract when you're looking at that. And then the lower picture, bottom left, clear lens, the light rays are coming into the eye with the image you're looking at, nice, clear, and sharp. And then as it gets gray, it starts to get cloudy, you lose contrast, you get a lot of glare because the light rays coming into the eye are just scattering.
You're just scattering, that's a good way of describing it.
Yeah, one of the most common symptoms of a cataract is glare.
Okay.
You know, patients tell us, you know, I'm just having trouble driving at night.
Right.
You know, there used to be the thought, well, we have to wait till your cataracts mature until we take it out. People would wait till their vision's really bad. But we've gotten away from that. Actually, Medicare has even, you know, said we don't need to have visual requirements for cataract anymore. We have to have a patient complaining of things, and usually it's that glare like we see on the bottom right, and people saying, you know, I can't drive at night. It's because of the cataract.
And at the end of the day, it saves everybody money. Let's go to, if we could, or let's talk about the cataract surgery. And I know there's so many, I guess the way of doing cataract surgery now compared to even a decade ago. Actually, we talked about it on the show. It's new like every year or so. So cataract surgery, we do have a slide, but I'd like for you to talk about it first. And we can like go back and forth to the slide in between. But how, like, what are you doing during the cataract surgery? Are you removing the lens completely? Are you replacing the lens? Explain to the audience what you're doing.
Sure.
Or would you like to go to this first so we can kind of explain the different types of cataracts? Would that be?
No, I mean, we could talk about different cataracts. I'm not sure how
Okay.
important that is because, you know, bottom line is you have blurry vision, and regardless
Gotcha.
of what the cataract is. I think the graphic was pretty good.
Okay.
We could show it if you'd like. But in cataract surgery, in theory, we're removing the dirty lens and we're putting a clear artificial lens in its place.
Which will never get dirty. It will always be clear.
Correct.
Gotcha.
Okay. So what we do leave in place from your original lens is the outer capsule of the original lens. So we make a small opening into the lens. We take out all the contents. We put the new lens in its place.
And this is where we can show slide 9. Okay, go ahead. I'm sorry.
No,
I just thought
sure.
it'd be easier to describe it that way.
And what can happen, once a cataract is gone, it's gone forever. You can get a clouding behind the lens implant that's in your eye, because remember, the outer shell is of the original lens is in place. If you look at step 3 there, we're putting in the new lens into the outer shell of the original lens. The back part of that can get cloudy. We call that an after cataract or a posterior capsular opacity. If that happens, which it happens in at least half of the patients, we do a laser that takes about 30 seconds. It doesn't hurt at all. No anesthesia or anything like that to get rid of the cloud.
And so that's this. If someone had cataract surgery years later, they may develop the other one, and that's what you're talking about. So
It could be days later. It could be years later. Everybody's different, or it might not be ever.
Okay.
But that's, we call that an after cataract. The actual cataract can never come back once it's gone. The plastic that's going into your eye, it's a piece, usually the lenses that we use are made of acrylic plastic. They're going to be there much longer than we're going to be there.
See, and that's amazing. It's plastic. They last forever, right? This would be the one good time that plastic is good to last forever. If I talk to all the millennials out there, I've got a 17-year-old. It's like, don't drink plastic bottles, Mom. And I respect that. So I don't want to blow through everything because I want to talk about glaucoma because we're starting to get questions in from the audience. I want to cover the basic big ones. So Lasik, we talked a little bit about cataract. Let's talk about glaucoma because then we're going to start getting floods of questions in from the audience. You're a glaucoma guy as well, right? What is glaucoma, the pressures? When people go to an ophthalmologist, sometimes an optometrist, when they're taking pressures of the eye, explain why. I used to hate that, but now that I understand why, I get it. So please take my pressures. What does that mean?
So glaucoma is a disease where usually, but not always, the eye pressure of the eye is high. So the eye is a closed system. It's a ball. And it makes fluid inside and it drains fluid inside. And that something can get wrong there where the eye pressure goes up, which can cause damage to the optic nerve. That was the cable that Dr. Del Torre showed us before that connects the eye back to the brain. So pressure on the optic nerve, you can start to lose some of your side vision, and with time, you could actually go completely blind from glaucoma. Glaucoma is a good thing to talk about, good reason why everybody needs to get regular eye exams. Because you typically don't know if you have glaucoma. It's asymptomatic.
Right.
And believe it or not, you can start losing some of your side vision and not know it. I'm sure Dr.
Because it's so gradual and you just get used to it, is that why?
Yeah, I'm sure Dr. Del Torre and myself, we both have had patients come in practically blind. They're looking through little tiny holes of vision left, and they didn't even realize they were losing their vision. It's very slowly progressive over time. Only caught on an eye exam, and that's why you need to get an eye exam. That's just one of the things that you can find on an eye exam. You can find all sorts of diseases. Every day we find people who didn't know they had diabetes or high blood pressure or other things that we find on an eye exam.
All kinds of optic nerve happiness too. I mean, you can find all kinds of things with checking out the optic nerve. So when we're talking about glaucoma, we're talking about the pressures. In my head, although you said it's its own isolated capsule, so does high blood pressure walk into that? Is there anything preventative for glaucoma? Is that something that's genetic in general? Do you know if you're going to be a glaucoma patient going forward? Dr. Della Torre, you're nodding your head, so you get that
so typically the glaucoma patient, there's usually family history, so we will go into that. Also, there's some risk factors, so African Americans are higher, also Hispanics are higher risk. And so there's other things that we look in the eye exam, being nearsighted, having diabetes. High blood pressure is not a risk factor, and you would think that high blood pressure, high eye pressure is linked, and it's not, because the eye, as Mark said, is a chamber that is enclosed, so the pressure of the blood coming into the eye does not affect the eye pressure. And so you can have low blood pressure and still have high eye pressure because they're completely different. And so the eye pressure we measure with different ways, and the normal range is 10 to 20. And so patients that develop glaucoma usually like the eye be above 20. It's not a pressure that causes pain. That's why it's called the silent thief of sight, because patients can have high pressure, but because it develops slowly and builds up slowly in the eye, you never develop pain. And so if the patients are waiting for pain to happen, sometimes they come and it's too late. So, and you can have glaucoma even with normal pressures. And so there's a variant of glaucoma called normal pressure glaucoma. So it's important to get that regular eye exam so we can determine. Part of the regular eye exam includes a pressure of measurement. And so, in the beauty of now treatment for cataract, for glaucoma, is that typically we start with an eye drop, But if the patients fail eye drop therapy, which is to lower the pressure of the eye, then we have surgery that is effective. And there's glaucoma specialists that only specialize in glaucoma surgery. But now, at the time of cataract surgery, we can do combined cataract and glaucoma surgery.
Which is amazing in and of itself. So what I'd like to do first, because we have a cool slide, and this is a slide that caught my attention when I was looking through all of these slides. Slide number 10, which is minimally invasive glaucoma surgery. Dr. Ellman, if you can tell us what we're looking at, just that little tiny black dot on the fingertip. I'm like, what's that? So anyway, in general, walk us through what we're looking at here.
You're looking at a very expensive tiny piece of metal.
Nicely said.
Yeah.
Okay.
But one of the most greatest advancements in cataract surgery. So one of the great things about cataract surgery is cataract surgery itself can lower the eye pressure. So you have glaucoma, cataract surgery itself will lower the eye pressure. And now we have devices, we have these MIGS devices, minimally invasive glaucoma surgery devices, that can lower the eye pressure even more. One of the more common ones that we place every day is called an eye stent, and that's what we're looking at in the picture.
Okay.
This was actually not designed by an ophthalmologist. And from what I understand, this was designed by somebody who had a family member with glaucoma, and they're like, we have to do something better for them.
Goodness gracious,
but
wow.
I don't know the full history. So you can see how tiny it is. Look how it is on the fingertip or on the penny. It's the smallest implant into the human body. So at the time of the cataract surgery is the only time an eye stent is put in. We take out the dirty lens, we put the new artificial lens in, I tilt the patient's head a little bit in the other direction, I put a special lens on the front of the eye, and I place this into the drainage angle inside the eye. So just in front of the iris, we can't see it, can only be seen with a special lens, is a little area where the fluid of the eye drains out. We put this in, and it allows a little greater fluid reduction. So it's, for patients who have glaucoma and cataracts, it's phenomenal because they're seeing better, we're often getting rid of their glasses, and we're often taking care of the glaucoma, lowering the pressure enough that they can get off drops or don't have to start drops and stay that way, hopefully forever. And then one thing I would just like to add really quickly from what we said before, besides surgical options and drops, we would also have lasers for glaucoma. So the laser we use is called SLT. It's a quick, easy treatment that takes just a few minutes, no significant anesthesia or anything, and that can also lower the pressure. So we have many different options for treating glaucoma. The important thing is knowing that you have it.
The important thing is, so go get it checked out.
Correct.
So this is me being a second grader right now. I'm looking at this finger and I'm looking at this dot. What tool, how are you doing this with that? It's so tiny. So what tools are you using? I just want to know how you do it. How do you get that itsy bitsy tiny little piece of metal that is very specific and intricate in the right place? I know you're talking about it goes into the fluid filled area. Is there a tweezer that's, I mean, I'm just curious.
It comes on a little injector. And then remember, we're working under a surgical microscope, so it's everything I'm doing is under a microscope. It's magnified.
Okay. Right.
Actually, if we go to the next slide, if we go to slide 11,
slide 11,
we can
please.
see an image of that.
I see. Okay, here we go. Okay.
So, what we're seeing here on the top graphic, we're actually seeing how the fluid is made inside the eye. So this is a patient where already had the artificial lens put in. That's what we're seeing in the middle there. And the fluid is made behind the iris, comes around, and it drains in front of the iris, and the eye stent goes in place at that drainage angle. So on the bottom left picture, we're actually seeing the eye stent, and then the bottom right as well, we're seeing the eye stent in place in the drainage angle. Again, this is not something you can see if you're just looking at somebody.
Right,
You
it's
have
just
to have
amazing,
a gonio prism on the eye to be able to see it. So I hold the gonio prism under the microscope with my left hand and put the eye stent in with my right hand. And usually it takes about an extra 30, 40 seconds to the surgery. It's actually very fast.
That is crazy amazing to me.
It's cool.
It is cool. I almost don't want to move off of that, but you can see what's coming up in slide 12 because I know this is cataract related, cataract surgery related, but in general, I'd like for people to see slide 12 because it kind of shows the tools that are being used that you all use. And either one of you, if you can talk through what we're looking at here, that's Dr. Ellman. So what are we looking at here? Because you said everything's magnified, obviously. Again, it's almost surreal to understand for someone whose area of expertise this is not. So explain what we're looking at slide 12.
Well, this slide is really cool because you talked about advancements, how things change.
Right.
Years ago, probably, I don't know what decade exactly, but for, some of my patients, they remember their grandparents undergoing cataract surgery, and they made a 180-degree incision into the eye, went in with a freezing probe, yanked out the dirty lens, which you waited until it was totally black and the patient was blind.
Right.
And then the patient had to sit in the hospital for 2 weeks with a sandbag on either side of the head so they don't move, because they didn't have stitches small enough to close the eye, and they didn't have new lenses to put in, so then they wore big Coke bottle glasses. Fast forward to today, it takes us about 4 minutes to remove a cataract and put a new lens in. And then a patient has a whole slew of options of different technologies we can use, and that's what this slide talks about.
Okay.
So, option number one that's relatively new is femtosecond laser-based cataract surgery, and that's a hot topic. A lot of patients ask about, what about laser-based cataract surgery? So the laser, which we see on the bottom left there, actually is outside the operating room, usually. The patient has a laser done. It takes usually about 30 seconds of laser, about 2-3 minutes with getting it all set up, painless, and the laser actually does some of the things that we would do by hand. So it increases the precision a little bit of the cataract surgery. The laser can also sometimes help us correct astigmatism, which is when the patient has an abnormal curvature to the front of the eye.
Okay.
That's one of the things we can correct to try to get rid of the need for glasses after the cataract surgery.
Oh, wow. Okay.
So laser's great.
Is stigmatism correction, has that been around for a long time?
It has been around for a while, correct?
Okay.
There's different ways to
I know
correct
that's also
it.
like if you can wear contacts or not, a certain stigma. I know we're getting off the subject,
Yep.
but anyway.
So correct, yeah. Astigmatism, if you have it, the abnormal curvature in front of the eye, we talked about the cornea where Dr. Della Torre operates, I tell patients it's shaped more like an American football than a Mexican football. It's got an oval shape, and so we can correct that at the time of cataract surgery, which will give you a better quality of vision and reduce dependence on glasses typically.
Gotcha.
And I want to add, if we can go back to slide 12.
Yes.
And this is something that I want to stress. We've invested resources to make sure that we provide to the El Paso community the latest technology. And we've also invested a lot of time in training our staff to provide the most precise and caring way to get patients through the process. So they look back and the experience is a positive one, so they can share it to other patients. And so patients from El Paso, they don't have to go out of town, they don't have to go to a big city, Dallas, Houston, or Phoenix. We have that technology here, and we have the specialized care here. And so including with the femtosecond, there's a machine like the second point there, the Aura. It's a machine that we attach to the surgical microscope that help us precisely measure the eye, especially on patients that are hard to measure, like patients that had prior Lasik, prior PRK.
Right.
Those eyes, their cornea is not virgin. The cataract surgery machines that measure for the lenses that we place, they get fooled by those corneas. So this technology helps us precisely measure those eyes. So at the time of surgery, we remove the cataract, we turn on that machine and measures at real time how the eye is after the cataract is done. So give us the most precise lens that goes inside the eye. And again, we have the most advanced lenses as well. So there's different lenses that can be placed inside the eye, and we can customize the surgery for every patient and every eye. So it's not cookie cutter, every patient gets the same surgery.
Nice, good.
Every patient, we can customize it. And so our staff and our technology allows us to provide that experience to the patients that otherwise they would think, if I want to get all this, I have to go out of El Paso.
Right.
We have it here.
And it's beautiful because I hate that one. Oh, I have to go to Dallas, I have to go here. I love that El Paso really is stepping it up, the medical game in El Paso, and has been for quite some time. We have so many questions from the audience. So I know that we have a lot more that's still here to talk about, but I really like to respect and honor the questions from the audience. So I'm going to blow through some of these.
Cool.
And if we can answer them quickly, or if they do not apply, say, Catherine, that does not apply. And then we can go on. So question here from the audience. My dad has had narrowing angles in his vision that developed in old age. Doesn't say what age is old age. Am I at risk for developing that? So when somebody is describing, so as doctors, and I know that you said people can describe pain or the way things in a million different ways. So somebody says narrowing angles. Dr. Della Torre, what would you think is going on here, and might this be a hereditary thing?
Yeah, so typically an eye that is a narrow angle is a far-sighted eye. These are patients that they have the ability to see at distance, they have difficulty seeing up close. And so a patient can ask to their eye provider, am I nearsighted or farsighted? Patients that are farsighted are usually at higher risk of having narrow angles. A farsighted eye is built as a smaller than normal eye. When you have a smaller than normal eye, then the drainage system of the eye is going to be tighter, and that's the narrow angle.
Okay.
So by asking your provider, am I nearsighted, farsighted? If they tell you you're farsighted, that tends to be a risk factor. And if that is farsighted, then most likely by genetics, daughter's going to be farsighted. So it's something that with an eye exam you can determine. There's a special lens that we use at the time, similar to the one used in cataract surgery, that help us determine. And if their patients have narrow angles, and we think that they're going to be at risk of developing narrow angle or close angle glaucoma, there's a preventive laser that we can use to stop that.
Interesting. Very cool.
Yeah. And I'll add that
yes.
also cataract surgery
Yes.
takes care of narrow angles. So you've got the small eye that Dr. Del Toro just talked about, and
Right.
your lens is getting bigger. It's the narrow angles in the front part of the eye between the cornea, the front surface, and the iris, the colored part. So instead of being wide open, that starts to narrow with time, and then it does run the risk at one point of shutting off. That's the dangerous thing. That's what
Gotcha.
we call an acute angle closure glaucoma attack. We can do the laser Dr. Del Toro talked about, quick, easy, takes just a minute or two, or
One-stop shopping.
cataract
I
surgery.
like it. Yeah. Okay, so once you're in there, there's so many things that you can do.
Correct. So if
Okay.
somebody has a narrow angle, like we talked about before,
Right.
get rid of the narrow angle, lower the eye pressure, get rid of their glasses, get rid of their blurry vision. A lot
Mm-hmm.
of things can happen in a 4-minute surgery.
Okay. We have not talked about this, but it is an issue all along. So the question from the audience is, what is macular degeneration? And then is there a treatment? And then age question mark. So that's, and again, this is my disclaimer. This is all the information we have. We do the best that we can with what we're given. So
That could be a whole topic
I
and a whole
know,
show.
right? But it is a question. So and maybe just first define what macular degeneration is. And if there is treatment, and again, are there certain ages? And I know ages are very, it could be any age. So Dr. De La Torre, you want to take that one on?
Yeah,
Or-
so
okay.
macular degeneration is a condition that typically is seen in Caucasians.
Okay.
So we talked about glaucoma being African American, Hispanic, but Caucasians tend to get affected by macular degeneration. The macula is the center of the retina. It's what we see 20/20 with. When the age-related changes affect the macula, we call that age-related macular degeneration.
If we can go to slide 6. Sorry, I know it's a pain in the butt, but slide 6 would help in what the explanation is. Go ahead.
Exactly. And
Perfect.
so the macula is the center of the retina, and that's where we see 20/20 with age-related changes affect the macula. The macula cells that help us see with precision in the center start to die. We lose central vision. It's one of the diseases that really affect patients because they try to read and they cannot find the letters. They very disabling, and it's
So from the front on, so they can see on the sides, but not so much straight in front. Is that what you're saying?
Exactly,
Okay.
and it's very
Okay.
frustrating. And these are the patients that go get checked for glasses. I got new glasses, I spend the money, I still don't see better. Because it's not that the glasses are wrong, it's that the vision is lost in the center. And so it's something that we try to prevent by using eye vitamins, and in some advanced cases, patients need laser or injections into the eye to treat. That's something that we can, as a comprehensive exam in our office, help guide the patient on what's the best way. But if it's something that requires injections or laser, we refer to a retina specialist.
So let's say with the injections, what's being injected into the eye and this is slowing it down? It's not going to correct it, but it's slowing it down. Is that correct?
Yeah, so I'm going to
Okay.
let Dr. Alman answer that.
Well, so
Yeah.
what is being injected? So what's the solution just physiologically, what's happening?
Sure.
with
Just
that fluid?
briefly, there's 2 types of macular degeneration, wet
Okay.
and dry.
That's right. I remember us talking about that. Okay.
Dry is more common, luckily doesn't lead to as much vision loss. Wet is less common, but leads typically to more devastating vision loss. The injection into the eyes to get rid of the abnormal blood vessels that are occurring in the wet type of macular degeneration. It's called an anti-VEGF, anti-vascular endothelial growth factor.
Okay.
One thing I would like to add for the patients who are watching that do have macular degeneration is that the nice thing to think about is the lights never go out on you. You can lose your central vision, and you may not be able to read, might not be able to see a smaller TV. Luckily, you've got great tools today with iPhones and iPads to help
Right.
people with low vision who don't see well. But you still almost always maintain your peripheral vision. So the lights don't go out, you don't lose your your
Okay.
independence.
Okay, and that's beautifully said because it's scary, you know,
Yes.
when you start talking about that. Another, I have not read this first, so this is going to be a dry read. I'm a 66-year-old woman, and I have been told by my ophthalmologist that one of my retinas or optic nerves is larger than the other. Two different things. How will this affect my risk of glaucoma, cataracts, or anything else? So again, that's a loaded question. I can read it again. Dr. Delatorre, you want to, or Elman?
Either one
Okay,
of us. So that's actually very common, something
okay.
that we find in an eye exam. I'm assuming she's talking about her optic nerves. So in the optic nerve, again, what connects the eye back to the brain, we look at it when we're looking in, and there's a middle part called the cup. And that cup is usually up to about 50% the size of the optic nerve, but it can get larger.
Okay.
And when it gets larger in one or both eyes, patients are now termed a glaucoma suspect, because it could be larger from glaucoma, but could very well just be the way they were born. Just like some people are born with big ears and they hear fine, you could have big optic nerves and you could see just fine.
Gotcha.
But that's where you wouldn't know until you have an eye exam, and then we do some testing to see whether it's something that needs to be investigated further or not.
Okay, nicely explained. Again, we've got so many from the audience. I love this. So Dr. Delatorre, I'm giving this to you. If I've had Lasik surgery, can I also get cataract surgery later? Perfect question. We kind of talked about that. Or vice versa. So I know we touched base on it earlier, but now it's a direct question from the audience.
Yeah, so the LASIK patient typically will have a lifespan where they'll go through their 70s. Cataract surgery most likely will be indicated in those patients, and the key is that you tell your surgeon that the patient had LASIK, because if the surgeon doesn't know that that patient had LASIK, it can fool the cornea, that measurement of the lens that will go at the time of cataract surgery. So it's very important that the patient tells their surgeon that they had LASIK.
Right.
And that's why we've invested in this technology that help us not get fooled at the time of cataract surgery with these patients. And then the opposite is true. And we have a lot of patients that have that misconception that once I get that lens inside the eye, then I'm stuck with my vision as it is. And that is not the truth. We can use the same laser that is used for LASIK and PRK to fine-tune the results of cataract surgery. And we do that often. And we sometimes do surgery and we aim for a target, and then the patients after surgery, they realize that that was not the target that they wanted for them. So we can now use the laser to fine-tune their cataract results. And so that's something that we can offer to our patients. So if you had cataract surgery and you're not happy with your vision, we can go ahead and change that and try to fine-tune the results of surgery.
I love that you can do that. I kind of want to ask this question because I think it's
Sure.
can I?
Go
so
ahead.
a question from the audience. You know, this is an ophthalmology show, right? Question is, I was wondering from the audience, why are one of the doctors wearing eyeglasses? So there's the question to you. Not everyone wants or has. So does anybody ask you that?
I get asked that all the
You
time.
do? Okay,
and I
beautiful.
purposely wore the rimless glasses tonight. So I was going to wear the fancier ones that have like
right.
thick plastic.
If I had to read the prompter, I'd be wearing glasses,
Right.
but I don't read prompters. I just do it all
So
here.
I'm hoping they wouldn't notice them. Darn it. But, you know, if I were to have known Dr. Delatorre and been in the position I was when I was in my 20s, I probably would have.
I'm with you. I'm kind of that same girl. Yeah, I'm with you.
So
okay.
you know, I don't wear contact lenses. So if I were to wear contact lenses, it's been proven in studies that your risk of a lifetime infection from contact lenses is greater than the risk of LASIK or PRK surgery. I don't wear contacts. I'm not all that active. You know, I exercise, but I'm not out hiking and mountain climbing or biking or things that my glasses or contacts are hindrance to me. So for me, it's just something I decided, not to do. But it's a great surgery, and if it's something that somebody wants to do, it gives them that independence from glasses.
Exactly.
Dr. Delatorre has had it done. He could probably answer that question.
And that's important. The fact that you can have surgery, that you're a good candidate, or you can afford it, doesn't mean that we have to do it.
Right.
And there's a lot of patients that come to me asking for surgery, but part of the evaluation is asking why now, why you feel this is the right time to do it. And unfortunately, I've disqualified patients that have come in, and I ask that question, and they tell me, well, my wife passed away, my daughter suggested that I should do something for myself, and I thought LASIK was the way. And this is a 55-year-old that already needs glasses for distance, glasses for near, and that's not the right way to go about the surgery. So LASIK, PRK, is not for everybody.
Right.
And so we have to go through the whole process to make sure that they're a good candidate. And if it's done in the right patient, done for the right reasons, then the success, it's almost 100%. But the opposite is true. Done in the incorrect patient, done for the wrong reasons, you can get in trouble, even with the technology and the surgery going well.
I'm going to put a plug for Dr. Della
Yes.
Torre because I've seen him with patients. He spends a lot of time with the patients, talking to them, showing them the different options, giving them a lecture, trying contact lenses to make sure that they're a candidate for it, that they should get it, not just that their eyes are a candidate, but psychologically that they're a good candidate to be getting the surgery done.
And that's beautiful.
Important.
It's never pushing anybody into anything. That's a beautiful thing. Question here from the audience. Again, I had a previous corneal transplant for
keratoconus.
Thank you.
You're welcome.
If I develop cataracts in the future, how will that surgery work? Is the question from the audience. Who would like to take that one?
It's going to
Dr.
be,
Della Torre.
yes, so it's going to be one of those challenging cataract cases that now we fortunately have the technology to be able to measure those eyes. And so that's a patient that it's going to be difficult to measure the lens that will go inside the eye. You want to have a lot of experience in the surgeon's hands dealing with those cases. So you want to ask your surgeon how many of these cases you've done, because you need the technology and the experience to be able to do cataract surgery. Those patients will grow to age where they'll need cataract surgery, and they need to be able to tell the surgeons, I want to know what is your level of experience dealing with this, because it's going to be a complicated surgery.
Right.
And I would say just level of experience in general, because the other thing you want to do, cataract surgery, if it takes a long time, can cause damage to the cornea, because you have an ultrasonic vacuum in the eye, and if you have a lot of ultrasound energy, it can damage the cornea. So you want a surgeon who's going to get in and get out pretty quickly and efficiently, so that you limit the exposure of the ultrasound to the cornea.
Okay. Makes perfect sense. Again, this is almost the same question as earlier, but I think it's flip-flopped. Am I able to get Lasik after having cataract surgery? It doesn't give the amount of years. So cataract surgery has already been done. They're asking about Lasik after the fact. And I guess, again, you kind of answered it depending on life.
So the answer is yes. Yes, they can. And so it's important for patients to understand that that lens that we place at the time of cataract surgery, most likely that lens will be the one that you carry for the rest of your life. There are patients that ask me, can I have the lens change years after? And in theory, yes, we can, but we are not fans of doing that surgery, because it's a risky surgery going into the eye. Typically, the lens has been in the eye for years. There's scarring that we have to break. So it's a complicated surgery. And most of the patients that go through cataract surgery and then get Lasik, we can very precisely change the prescription of the eye, that we cannot have that precision with the lenses power that we have available. So if the patient's fine-tuning of the prescription is very small, even if we were to choose a different lens, might not come in the power that that patient needs. So the laser can do it more precisely. So I would recommend the laser after cataract surgery than having the cataract surgery lens being changed. Even though in theory we could change it, we don't encourage that surgery.
That's also a good transition into ages for Lasik. If you maybe want to touch on that, Dr. Della Torre, when you get past a certain age, Lasik might not be the best option to get rid of glasses.
Right.
And there's options. The nice thing, we have a whole bunch of things we can do. And Dr. Della Torre, if you want to touch on that.
Yeah, so between 50 and 60, and every patient is different, the eye's age different, but between 50 and 60, that's where you enter the gray zone, where the lens is starting to change enough where cataract surgery and Lasik, they blend in that age group. And there is a patient that usually very classic, kids are out of the house, they now have the income, and they come to Lasik, like I like to say, late to the party.
Right.
And so they're in their 50s and they might want to get Lasik, but if we aim for distance, they still need reading glasses, and they're saying, well, why am I spending all this money? And so those patients that are in that gray zone, we individualize their care. But there are patients that elect to have early cataract surgery rather than waiting until the cataract develops and to be in their cataract age. They can elect to have early cataract surgery and replace their lens with a new lens. So Lasik might not be the correct patient the correct surgery for that patient that comes between 50 and 60.
Right.
So it's very individualized in that age group.
That makes perfect sense. Believe it or not, we have less than 9 minutes to go, 8 minutes to go, so I'm stopping.
Wow.
We have a ton of questions still, but is there something that you wanted to talk about tonight that we haven't talked about yet? Or if you want to expand on, because I always feel like, oh, the show's over and we didn't finish everything.
I would like Dr. Ellman to discuss the lenses. I see a lot of the patients before and after, and a lot of the patients want to know about the different lenses that we have, and what lenses are covered by the insurance, what lenses are not covered by the insurance.
Nicely asked. Okay.
So if we go back to slide 12 for a second.
Okay.
We talked about some of the technologies that are available for cataract surgery. A top one femtosecond laser, pretty awesome. Every time we use it, there's a fee associated with it, so that the patient does have to pay. Everything on this slide costs a little bit extra to the patient, so there's out-of-pocket costs. We have financing and we help the patients when able, but there are costs. Femtosecond laser is awesome. If it were free, probably everybody would get it. It's not groundbreaking, though. I don't think a patient should stretch to get a femtosecond laser cataract surgery if they don't have the finances for it.
Right.
So if you don't have the money, you could have great cataract surgery without the laser. The second step down from that, the Aura, that's a really, to me, just a great technology. If a patient has a little bit of an abnormal shape to their eye, if they've had previous refractive surgery like Lasik or PRK, we get better accuracy because this is repeating measurements live during the surgery in the operating room.
Okay.
And then the final thing on this slide is just there's a bunch of advanced technology lenses on the market. There's multifocal lenses, there's toric lenses, it's just two examples.
The next slide has the lenses.
And that's number
Yeah, if you
13,
wanna
if
go
that
to the
helps,
next
slide
slide.
13.
So, most patients, when they don't pay anything extra, they get a monofocal IOL, intraocular lens. And then you have, that is aimed at one point in space.
Okay.
So usually most patients get both eyes at distance vision. But, in today's day and age, sometimes our lives are closer up.
Right.
We're using iPads, iPhones. My own mother, actually, I did her cataract surgery about 2 years ago, and she's a homebody. She loves playing on her phone and her computer and her iPad. So I set her eyes more for close than for distance. And she loves it because she does most things at home without her glasses, and she's actually even doing most things at
Thank
distance.
God she loves it. Can you imagine the rest of your life having your mom mad at you? Go ahead,
I
sorry.
would send her to Dr. Del Torre and he would fix it, so I'm covered. But that's actually a great option for some patients.
Right,
both eyes near.
exactly,
Or you
yeah.
could do monovision. We talked about that before, one eye distance, one eye near.
Yeah.
We have toric intraocular lenses that correct astigmatism. So if you have an abnormal curvature, the football shape to the front of the eye, we can correct that at time of eye. And then we have multifocal lenses. I don't think we have time to talk too much about it, but those are lenses that focus distance and close up, both eyes at the same time.
Those are fascinating. So do talk a little bit about that, because I hear about that here and there. How does that work? Is it the lens that's planted? Is it a weighted lens, or Dr. Del Torre? He's like, oh, I want to answer this one. I want to answer this one.
This is where I really enjoy talking about this, because the lens technology is designed where the lens has rings within it and breaks the light into a spectrum. And the lenses, we're good, but we're not God good. And these lenses are not for everybody.
Okay.
And so we have to mix and match the patients and the eyes with the correct technology. So even if you can afford a premium lens like a toric lens or a multifocal, maybe your eye is not made for that lens. And it's important that conversation is had with the patient prior to the surgery. And so these lenses, what they do, light comes in, breaks the light into a spectrum, and the patients can see distance, computer, and near. But the way that it does it is by taking away from the sharpness. So these patients can see a range of vision, but at neither of those ranges, the vision is perfectly in focus. So you take a hit in sharpness for quantity and the independency of the lenses. And the patients need a lot of light. So I tell the patients that when they have a multifocal lens, they need 2 L's, light and lubrication. They need a lot of light to be able to see. Those lenses are not designed to be used in a dim restaurant or to read at night in low light. They need a lot of light, and when the vision blurs on them, they need to lubricate their eyes with artificial tears. Because they don't have light and lubrication, those lenses do not perform as they are sold and intended.
So, silly question maybe, all ages? Who is most interested in this multifocal lens?
Is a patient that has to have a healthy eyes. Patient with
Okay.
glaucoma, not a good candidate.
Gotcha.
Patient with diabetes, not a good candidate. Patient that has macular degeneration, not a good candidate. So that's why the full eye exam has to be before, and the measurements have to be right. So not every patient can get this technology. So we
Okay.
have to match the patients with the correct lens.
But there's no age limit.
Okay.
You know, I think younger people tend to be a little bit more interested. For me, I think that especially people who use their cell phone a lot.
Right.
Because if you're focused at distance, you want to use your cell phone and be able to see it clearly. That's where a multifocal lens is really nice. And most patients with a multifocal lens are really happy. One thing I also just want to expand on what Dr. Della Torre said before, or you, I don't remember, Catherine, is going out of town. You know, a lot of patients,
Right.
you talked about having to go out of town for surgery. You know, we see that sometimes. Patients who have the means go out of town. You know, in our group and a lot of other doctors, you know, in other specialties as well, do more procedures in El Paso than most people do elsewhere. I was actually at the Mayo Clinic, you know, not that long ago, when I was talking to somebody that said, oh yeah, we do a ton of cataract surgery, and they do about 1/10 of what myself and my partners do in
Oh
a
my
week.
goodness, wow.
So, and you know,
Yeah.
what microsurgery experience counts, you know. So with the experience that is almost unparalleled in the world, combined with the technology, patients don't have to leave El Paso to get, you know, the absolute best when it comes to cataract surgery, as well as a lot of the other things in town.
And that helps with expense, it helps with comfort, it helps with who your support system is, it helps with everything. And I agree, we've been knocking it out of the park when it comes to things here. My gosh, we have less than 2 minutes left, and I'm just gonna answer this question again. After or at the same time as cataract removal, cataract surgery, can LASIK be done? So, yes,
we can do
I
it.
know we've said that a couple of times, but I feel like it's so worth repeating
It
on
would always
that.
be done after, not together or before.
This is RK surgery 25 years ago. Now has cataracts. Can they have cataract surgery? We've got a couple of seconds.
We recommend cataract surgery, and we highly recommend using the Aura technology to help the eye measure precisely at the time of the surgery.
Okay, so if you had, yeah.
If there's any questions that we can't get to, patients can always call or text us with the questions.
That's my
and we're
next
happy to
slide.
help.
So we actually had a question is, hey, what's the phone number? Where are they? So again, this is Southwest Eye Institute. They have 2 locations, one on the east side, one on the west side. The telephone number for both locations is 915, El Paso area code, 915, because we're in various areas, 267-2020. So February 1967, just think of my birthday, February 1967, 267-2020. So again, Southwest Eye Institute, just Google that or search engine that, 915-2620.
And that is a textable number, so if patients have a question and want to text us, or on our website there's a contact us form they could go to. It's eyesvip.com.
I like that, eyesvip.com. Again, we've been talking with Dr. Mark Ellman and Dr. Javier Della Torre. Our 2 lovely medical students this evening have been Melissa Huddleston and Heather Jones. And again, this was sponsored by the Southwest Eye Institute. And a big shout out to the El Paso County Medical Society, who's been doing this show for over 3 decades now. I'm Catherine Berg, and you have been watching the El Paso Physician. Good job, good job. Look at this. Do you want some of these? So here's some. I'm not gonna.